Good evening, everybody. Welcome to another Conversations with a Doc. This evening, we're really very lucky to have Dr. Lisa Schulman from the University of Maryland. And I'm going to let her tell you about her background, and she'll do a little talk, and you'll all have an opportunity to ask questions. So here we go. Lisa?
Okay, well, thank you very much, and thank you for inviting me to participate tonight. I wanted to kind of try something new, and so I suggested, and you guys accepted the idea of talking tonight about what frustrates you about healthcare. Here's my take. What's yours? As you heard, I'm professor of neurology at the University of Maryland School of Medicine. I am director of the University of Maryland Parkinson's Disease and Movement Disorder Center, where we have 6 Parkinson's specialists and a full and comprehensive program. I've been doing Parkinson's care, frankly, for about 30 years now. It's really a pleasure to be with you. When it comes to this topic, I'm going to start with a brief introduction, and I really welcome all of you to participate because certainly I'm sure there isn't a single person who isn't at times frustrated with healthcare, and you can ask general questions about our healthcare system and the difficulties you've encountered, or you can ask more specific questions about Parkinson's focused questions and regarding the healthcare system. So having given you that introduction, let's just sort of dig in. I'm going to be talking first from the perspective briefly as a so-called Parkinsonologist, a physician, as well as from the perspective as a patient, because every one of us is a patient at some time, and as a caregiver, because I've had substantial, unfortunately, experiences as a caregiver for family members. So I know that from any of these perspectives, there are many issues that you encounter that are quite difficult about our healthcare system. So let's start out by being clear that really we're all in the same boat. And what I mean by that is that we're all stuck in a broken health system. You know, there's lots of healthcare platitudes out there, and many of them are misleading. One of them is that we have the best health system in the world. And, it's absolutely true that we do have the very best trained clinicians and the very best technology and the very best resources. As a matter of fact, you probably can't find a practicing physician in academics like myself who doesn't receive one or more email messages from medical graduates around the world every day asking if they can come and work with me in my lab. And I don't have a lab, in research. I do a lot of research. They all want to get into the US health system because it's recognized around the world as being the absolute top. And then with the best training, and this is true. But unfortunately, we allocate our healthcare dollars poorly, and therefore the system really doesn't work the way in which it should. Another common platitude that's misleading is that your healthcare decisions are solely between you and your doctor. That might have been true decades and decades ago, like when I was a child and watched things like Marcus Welby. Probably nobody knows what I'm talking about, but the fact is that the way things have evolved, increasingly, the healthcare, your healthcare, your doctors, your nurses, your various kinds of clinicians, they don't have the autonomy that you might think or might expect. And, if healthcare decisions are solely between you and your doctor, then why are there so many insurance denials all the time? And another platitude is you have access to all therapeutic options. Well, if that were true, then why are only certain things covered by insurance? So every single time uh, your physician is with you and deciding how to care for the problems that you have, the physician at the same time has in the back of their mind the kinds of things that they may want to do, but that will very likely result in a lot of calls and refusals and denials and appeals over time, which is frustrating to you and frustrating to your physicians. You know, just as I was working on thinking through the kinds of topics we might talk about tonight, just last week, there was this article in the New York Times, and it was titled The Moral Crisis of America's Doctors. And what they said was that, you know, I'm sure you've heard the term physician burnout, you know, or you could be talking about any kind of uh, nurse or nurse practitioner or physician's assistant or physical therapist. Many people talk about burnout. And the fact is that it's not from working too hard. That's what most people think that it means. But what's been found is that in the majority of cases, it's because our health system makes it so difficult to care for patients. The phrase that was used in this particular article, which I'd heard before, is the concept of moral injury or moral distress on the part of the clinical, the clinician. And this is an emotional wound when the job becomes ethically compromising. You know, you go into the healthcare profession with the idea that you want to provide the best quality of care and use your training in the best possible way. But when you find that you cannot do that and you have to be compromising, this is ethically challenging. So this comes from times when the demands of regulations and administrators and insurers are forcing health workers to stray from their ethical principles and core values. So what are some examples? Like when it's not possible to order a needed diagnostic test. This is not uncommon. You know, you might put in an order in the electronic system, and then you might get a response that you can't do that test until you have done these other things. Or they may give you a check off of what's the reason why you're ordering this. And if you don't come up with a reason that they agree with, they would say, no, we won't proceed, we won't cover that. Another example is when it's not possible to prescribe the best medication. That's also extremely common, and that oftentimes the the clinician is told, well, you can't try that until has this person tried all these other things? They give you a list. You have to like provide a document to show that you've tried all these other things. Well, there are some situations where you absolutely know that those other things are going to either be inferior or even worse than that, detrimental possibly. But yet you have to sort of fight these battles. You can imagine, you know, when you see a lot of people, how this compounds itself in terms of not only extra time and effort, but also the emotional uh, the emotional consequences of not being able to do what you know is right. This can come up when you feel that a patient is doing so poorly, they need to be admitted to the hospital or perhaps go to a rehabilitation facility. Maybe they are living alone, they can't care for themselves. It's clearly that they're falling, whatever it is. Well, you know, not so fast. It's become extremely difficult to admit a patient without a very high level of acute illness into hospitals. The olden days, you could admit almost anybody. Today, you know, it's like some people say, like hospitals are like a cluster of intensive care units because you have to be so very, very ill to get into a hospital. Uh, Another example is when it's not possible, when an insurer will only cover a treatment if you've tried less expensive options, or they may have an approved list of medications that they've made negotiated to have reasonable prices on, and they'll only cover those medications. Well, sometimes those medications are not going to do what you need is necessary for your patient. Another example, which is very difficult for your clinicians, is when productivity is being measured on an hourly basis. And this is true because of the increasing corporatization of healthcare, such that the healthcare providers are being frequently told about the metrics of the speed of that they're seeing patients, the efficiency, and something known as RVUs, relative value units. This is a metric used to measure physician reimbursement. And so all this data is being collected all the time, and there's mostly an emphasis on these metrics rather than quality of care. And a final thing that I think, among many things that contributes to physician burnout, and actually, I mean, many physicians leave medical practice for the reasons we're talking about. And I've known many of them over the years who've left clinical practice to go into, maybe they go into industry, working at a drug company, a device maker, because we're near the seat of government here. Many people who leave to go to the FDA, for example, or the NIH. But part of it again is that doctors are increasingly the scapegoats of systemic problems within the healthcare system. So that because you don't see all the background of the regulators and the administrators and so forth, or the insurers, you see the face of your physician. And therefore, the physician very often is in the role of looking as if they are the denier of healthcare, which is precisely what most people do not want to be seen as. So, a lot of what we're talking about is this loss of autonomy. Um, what must be included. For example, there are literally lists, check-off lists of what must be included in your history, what must be included in your examination, even if you feel that that is not pertinent to the patient's problem that day. It wouldn't be accepted for reimbursement that visit unless you went through a much more long list rather than a more focused look at the problem at hand. Another thing we already been talking about, the recommendations are oftentimes limited. There are new medications coming out. People come in with the advertisements, things that they have downloaded from the internet, information they have learned from direct-to-consumer advertising on TV and elsewhere. But the fact is that you may be unable to access those things for the reasons that I've already said. And then the documentation, well, we could talk forever about that because it is extremely lengthy and time consuming and has to be done in just such a way, or else not only is it considered not done properly, but unfortunately it's even that one could be, you're constantly told a physician can be guilty of fraud if they do not have everything you need in the documentation. All these insurance authorizations delay diagnosis and treatment. And we all know examples where people have had such long delays that it has in fact been detrimental to their health. There's just no question about that. And every medical office requires literally an army of office staff to manage all of this. And this is just one of many examples of how our healthcare dollar goes in a poor direction. And then unfortunately, because uh, lots of the treatments have a huge cost associated with them, a huge price tag, some people can't access the best treatment at all. That's also a tremendous cause of this moral distress. So, our healthcare system is broken. There are different rules for different people. The rules are constantly changing. And one of the things that is also quite difficult is that many people believe that most symptoms are treatable and that most conditions, even aging, are or will soon be curable. And of course, the reality is that there are limits to what we can accomplish, and that is hard for all of us to accept. There's no question. So, I'm going to, in a moment, open this up to questions. I want to just make a segue here to my perspective as a patient at times and as a caregiver. And I think um, the most important thing that I thought about was how frightening it is when you are ill or when somebody you love is ill to feel so vulnerable and out of control. It's a much more frightening experience than you might think until you're in that situation. And I know that many of you have experienced those moments, and whether it's because of symptoms of a disease or potential side effects of a treatment, and you don't know what's going on and you don't know what to do, it's very, very difficult to feel in that vulnerable position. Oftentimes, it's vulnerable because there are problems with communications with your doctor, your nurses, your therapists, and so forth. And that is a pervasive problem, there's no doubt. And there's also communication problems between your health team, between your different clinicians. And I think that there are some improvements on that score. And the electronic medical record has, I believe, made some improvements because of the patient portal, which is a whole lot better for messaging than trying to play phone tag with people. And also the fact that very often your clinicians can find each other's notes on the electronic medical record. So those kinds of things have made it somewhat better, but far from perfect, that's for sure. So at this point, I'm going to turn it over to you, and I really look forward to having you express whatever your thoughts are, even if you are very frustrated. I'm very open to your thoughts.
Okay, I'll ask some of the questions, excuse me, that you all submitted earlier. The first one is, are there more movement specialists coming on board? There seem to be so few, and therefore the wait to be seen is months, even if you are already a patient with that doctor. And included in that question, are there any solutions as to how to get in with them within a reasonable time frame?
Yeah, so of course, in as an academic movement disorder specialist, we are continually training new movement disorder fellows every year. In fact, this past week, we had the graduation of our fellows, and we trained three movement disorder specialists this past year. We have two more coming in just a couple of weeks. Uh, and I know that all the movement disorder centers have fellows that are constantly being trained. At the University of Maryland, we are proud that our graduates, and I've been at the University of Maryland more than 20 years, our graduates have started movement disorder practices or entered other practices throughout the region, throughout Maryland and Delaware, and many other locations right in this region, actually. So we've we're working on that problem. Having said that, I understand what you're saying, that the wait can be very long. You know, that's a source of frustration for many of the physicians as well, because there are, there actually always are ways to find space for uh, new patients or follow-up patients. But the problem is that most doctors have a lot of cancellations and no-show patients on their schedule. So we have the tremendous frustration of that we have people saying, just as the questioner just said, there's such a long wait. And at the very same time, we might go in and find ourselves sitting there twiddling our thumbs because we had a full schedule, and then the night before somebody canceled, and then somebody doesn't show up, and such. Some things happen, there's no doubt, but sometimes it's just a matter of somebody just, it's inconvenient, they decide not to come. So we're always struggling with this problem to figure out how to improve this mismatch. What is the best way? I think most physicians have a waiting list. I know I certainly do, and my colleagues do. So, if you call and ask to be put on the waiting list, if there isn't an earlier appointment, and specifically say, I need to be seen soon because of this reason, put me on the waiting list, we would certainly at the University of Maryland, we work towards using our waiting list to fill in the spots as people cancel. That would oftentimes be a late cancellation. So I hope that is helpful. Was there another part to that question that I missed?
I think you got it. More movement specialists coming on board. What do you do about the wait, and solutions as to how to get in with you in a reasonable time frame? So I think you hit all those. So the next question, what is the best way to communicate with doctors who don't seem to listen or to address my concerns?
Well, that's a great question. First of all, I think that, it's helpful if you bring a list so that you are not only enunciating and articulating what's going on with you, but that you also have a clear list. And I oftentimes talk about the importance of having a prioritized list, so that, sometimes when we're, right there in the midst of an office visit, we might just sort of like blurt out various things that just come to mind, or maybe something that's been very recent and disturbing, and that may not be your most pressing problem over the last couple of months. So, consider that in any visit, not only is there only so much time to get into depth about, so, a certain number of problems, but that one of the main things you, as a patient, main objectives for your visit is to be clear about what you most want to get out of that visit. What do you want to leave that visit with a good discussion about? What are the options for treatment for your most priority problems? Because you don't want to walk out the door and say, oh, I forgot. I ended up talking about, I had a bad night's sleep last night, and all sorts of things happened. Or, I had this recent fall, but perhaps those are unusual things. And maybe your main problem is that you've been experiencing tremendous difficulty, for example, with urinary function, or with your medicines wearing off at certain times of the day. So not only the higher priority problems need to be stressed. One way to stress that is to make sure that you bring in a list so that you yourself stick to that script, but that you could leave the list with your physician so that they are sure that's what gets into the notes for the day as well. I think that it's also very important that whatever is your most pressing problems, that to the degree possible, you come in with um, a detailed history. And, if we're talking about Parkinson's disease, if you are having difficulty with medication wearing off, if you're having difficulty with falls, if you're having difficulty with um, dyskinesia, involuntary restless movements, what is going to be very helpful to your physician is understanding how often, how frequent is this problem, and how severe. And so the frequency would be like, is it occurring every day? Is it occurring twice a week? Uh, Something really kind of specific like that. And then to what degree does it disturb your daily function? That's a very important question that makes a real difference in my mind as to whether something needs to be more aggressively treated. If you say that um, I would like to be able to go out to lunch with my friends, but sometimes I can't make it because my medication effects are unreliable, for example, or that you're having dyskinesia that's interfering, or that your speech is a problem, and so that you are avoiding social interaction. Any of those things that point out to what degree a symptom is disrupting your daily life is would be a big point to impress the physician who's juggling a lot of different problems at once about what should be addressed, and addressed aggressively.
Okay, next question. Okay, this is a longer one. Why do staff in some neurology offices or hospital clinics expect patients to fill in forms, supply insurance numbers, dates, etc.? Even worse, patients are directed to receive and respond to text messages, use online portals, which are super intricate, challenging, not user-friendly, and confusing to patients who have dementia, which is a huge proportion of PD patients. These expectations are often unrealistic, I feel, and frankly counterintuitive to the conditions that they are treating.
I think that's, also an excellent question. You know, in my introductory remarks, I talked about the offices being overwhelmed by the regulations and the layers of increased regulations and rules and uh, insurance needs and so on and so forth. And this has resulted in, the consequences is that the office staff is trying to find every which way to try to get a head start on getting all that information. Because if somebody arrives and then you try to get all that information, it slows the process down tremendously. And then if one person is late for their appointment to see the doctor, then everybody ends up being late all day long. So it's like a snowball effect. So that is the reason why, and I must say it is super annoying. There's just no question. Every time you make an appointment, you have all these things you're supposed to complete. And you're quite right. Not everybody is even able to do that. Obviously, if you cannot do that, I mean, one thing would, of course, be to ask a friend or family member who could help you. But otherwise, probably arrive early, quite early for your appointment, so that there is the time to take care of providing all that information without being late for your appointment.
Okay. I'm frustrated by not getting to see my provider in a timely manner and then not having enough time to spend with my provider once I finally do get in for my appointment.
Uh, you know, the I mean, at the University of Maryland, we allot 1 hour for a new patient and half an hour for a follow-up patient. And all of us are, we have no choice. We have to find ways to try to keep our work within those parameters, or else the subsequent patients will be understandably disturbed. When patients say to me that they were unhappy with the wait, one of the things I oftentimes say is that if you make an appointment first thing in a session, which is my case, I see patients in the morning. So I say, if you come early, then you will be seen virtually on time because there won't have been the problems of the snowball effect where you get later and later as the day goes on. And some of that is, due to, it's nobody's fault, but, if any patient takes longer than the half an hour, or if they are late, if they arrive late, and so forth, all these things end up causing a time crunch as the day goes on. I think that, there are some practices where the time periods for new patients and follow-up patients is less than what I just said, an hour for new and half an hour for follow-up. And I really can't even imagine how you would see a follow-up Parkinson's patient in less than half an hour, because we have so much to talk about all the time. So, I mean, for one thing, you might want to make sure that you're working with a clinician who does provide a full half hour for a follow-up visit. Another thing is that sometimes you can't get everything done you want in the half an hour, and you might ask for an earlier follow-up appointment. That's, if I find that somebody has complicated problems, we might say that we weren't able to get into all of it today, and so we'll have you come back perhaps in, a month or two, rather than 3 months or 4 months or 5 months. So, I mean, I think that this is a frustration that we all have, but on the patient and family side of things, it's important to use the time wisely, partly in the way that I said, to organize the visit. And I mentioned coming in with a good list of the problems, the prioritized problems, but there are two other lists that you should bring. One is, of course, your medication list with details. And the third is your question list. And as the time goes between your visits, whenever a question comes to mind, you should jot it down, because again, to use the time most productively, you want to organize the time. Look through your question list and prioritize that too, because you may not be able to get through it all. Make sure that the most important questions you can rely on with the list. I find it very helpful when people do come in with lists, and I pay attention to the fact that I want to try to get through that list so that they're satisfied.
Can you provide any insight into Bill Curtis's Parkinson's treatment?
Ah, well, Bill Curtis is my patient.
Oh, so no.
No, I mean, no, he has been very public about what he's doing, so I can talk about that. He is on a ketogenic diet and fasting. He fasts and is on a ketogenic diet. And I can't cite chapter and verse of what the particulars are of that, but it's fascinating, to be honest. I don't. I mean, I think that it's something that we need a large study of, and we haven't had a large study of, because when you have something that looks promising in a single patient, it's difficult to know what to say. Even and in his case, it is true that over time, because I've been caring for him for a very, very long time, that it appears to me to have been beneficial for him. It's not an easy diet that he's on. There's no question. And like I say, I wasn't prepared to talk about it today, so I can't describe it fully. But he is quite diligent about it, and he says that if he goes off the diet, that he feels that he loses ground. He's had his Parkinson's disease for quite a long time now, and he has been unusually stable after many years of Parkinson's disease. So I think it's you know it's right now hard to explain. There are some theories as to why a diet like that might be helpful. Bill Curtis, to his um, to his credit, he's been going to meetings and talking about it and writing about it. And I think that, there'd be value in having a systematic, high quality study of what he's doing.
Very interesting. Did he start that diet right, very soon after he was diagnosed?
No, and that's what made his experience all the more amazing, because he was not doing particularly well at one point, and then
Huh?
he started the diet, and he improved.
Okay, next question. Does the use of levodopa create a condition that over time that inevitably leads to dyskinesia?
Dyskinesia does not occur in 100% of patients, but it does occur in the majority of patients over time. And although it is oftentimes assumed that levodopa causes dyskinesia, that is somewhat misleading, because if somebody who doesn't have Parkinson's disease takes levodopa for years and years, they will not develop dyskinesia. So it is instead an interaction between the levodopa medication and the underlying um, uh, injury in the brain, that particular injury in the brain that is the substrate, the basis for Parkinson's disease. It's an interaction between the medicine and the changes in the brain. We know that that's absolutely true, and I'll tell you why. Not only, as I said, if you don't have Parkinson's, you won't get dyskinesia from levodopa, but another excellent illustration is that there are times where people go undiagnosed or misdiagnosed for many years. And it happens less and less because we're more sophisticated in general medically about Parkinson's. But nonetheless, there are some people who have come in and have not been diagnosed and might have close to 10 years of Parkinson's disease, but they never took medicine, and they come in a extremely disabled condition. And of course, you start medication. So the important thing is this: you start medication, and it's just a miraculous situation. Somebody is in a very disabled state, and it couldn't be more heartwarming to see such an incredible turnaround. But those people who have come in and started levodopa at a very late point, they develop the side effects of motor fluctuations and dyskinesia relatively soon after starting the medication. Sometimes I've seen it within 6 months or even less in a situation like that. Whereas in the standard situation, if somebody developed the symptoms of Parkinson's disease, they were diagnosed after maybe a year or 2 or 3 of the symptoms, then they started levodopa, they wouldn't be expected to develop dyskinesia for years, oftentimes for a good number of years. So this is another illustration, the story I just told about patients like this who come in, they have advanced Parkinson's disease, they take the medication, and they develop the side effects much, much quicker This illustrates how it is an interaction between the medication and the underlying brain injury.
So I have another question that's more general, I guess. How do you feel about when you have a patient visiting you and they would like to tape the conversation? When my sister had breast cancer, and we would go to the oncologist or we'd go to the surgeon, and there was so much information, and it was impossible to remember it all. And they were fine about it. We would tape the conversation, we'd go back, we would talk about stuff, and then the memory is funny. So then we'd have to listen to the tape to get it straight. How do you all feel about that?
Well, I'd be interested to hear if anybody has had any negative experiences in this regard, and whether there have been people who, other physicians and such, who have refused it. I have not been, I've been open to it. And I think all the more so lately, because with the advent of our smartphones and
Mhm.
FaceTime and so forth, it's increasingly common to have somebody ask if their family member can join, sometimes from another state and sometimes from another country in the world. Can be quite far away, actually. So increasingly, we are being connected with others electronically, and the recording seems like just one additional step beyond that. Uh, I mean, I think that, if it's all an ordinary kind of a situation in terms of a normal routine visit, that would be perfectly fine in from my estimation, unless it was something maybe more controversial where somebody might find themselves feeling uncomfortable by it. But I just wonder if anybody has ever have been refused.
We never were. I mean, with the surgeon, with the oncologists, all of that, they actually kind of encouraged it because it meant that she wasn't calling to ask more questions. It was right there on the tape. So just curious. Another question that just came in. What are your thoughts about high dose thiamine B1 therapy?
I don't have any thoughts on that because it hasn't been properly tested.
Okay, that was a short answer. That was a good one. Any other questions? Michael, did you see any others? Yes, no.
It looks like there are.
Oh, wait, here's another one. How would a patient determine whether to ask his GP or his Parkinson's provider for a prescription change related to the psychological impact of, uh-oh, I don't know the rest of the question.
Oh, I see it though.
Oh,
Um,
okay.
for a prescription change related to psychological impact of Parkinson's
Ah,
process of elimination. In this case, the GP and PD providers are not in the same system. For a prescription change related to the psychological impact of Parkinson's disease. Oh, I see. The question is whether to ask your GP or your Parkinson's doctor for prescriptions about the psychological impact of Parkinson's. Well, I mean, I think that, I mean, so I assume that the question is, psychological impact could relate to depression, anxiety, or even potentially, other psychiatric symptoms like hallucinations. We deal with a lot of different types of psychiatric symptoms, apathy. And so, I think that your Parkinson's specialist is likely to be more attuned to the range of associated psychiatric symptoms, and what is, the range of it, and the relative uh, intensity of these symptoms, in terms of whether this is kind of more like the routine problem or maybe goes beyond the routine problem. And that would be important because if somebody seems to be having difficulty with adjustment to diagnosis after a while goes by, or maybe they describe that they have periods of the day where they are quite anxious. In those cases, I would, comfortably begin medication for those problems. On the other hand, sometimes the intensity and of the symptoms go beyond what is common, and maybe we've already tried one or two medications, and that's a situation where you would you would welcome getting the input from a psychiatrist, because it's more than the common situation. So getting back to the main question about whether you want to go to your Parkinson's specialist or your primary care physician, I think that the Parkinson's specialist would have more of a handle on what is the common presentations within the Parkinson's population. And, we know that about 40% of our patients, 30 to 40%, have clinically significant depression or anxiety at different times.
Okay, we've got a couple more here. Do you expect the availability of care to get worse as the United States population ages and we have fewer healthcare professionals immigrating to the US?
I think that, unfortunately, this is an example of our broken healthcare system, that the it doesn't make any sense, quite frankly, why certain kinds of specialties should be so much better remunerated than other specialties. And for example, we talk about the aging population. Virtually nobody wants to go into geriatrics. We need so many geriatricians, but nobody wants to go into geriatrics because it has, frankly, I mean, the pay is very poor for a geriatrician compared to many other specialties. And, we only need so many dermatologists and radiologists, and these are some of the higher paying specialties. So, I mean, it shows you how weird the healthcare system is, because you'd think it would be supply and demand, but it's not. We need more people who specialize in aging. There's no question about it. And especially as the population ages, as the questioner asks. So I think it's a real problem, undoubtedly true. Because the caring for people who are aging is quite different in terms of the sensitivity to medications, the inability to tolerate so-called polypharmacy, as well as younger adults. There are, of course, living with emerging disability, living with the vulnerability of aging and possibly isolation. There are so many different problems that are particular to the aging population.
Okay, we've got a raft of questions here. Telehealth appointments, are they still necessary since COVID has decreased? And does insurance cover them at a higher rate?
Yeah, a great question about healthcare policy. So there is a struggle about what's going to happen with telehealth appointments. They were permitted. They weren't reimbursable until COVID, telehealth. And then they became reimbursable. And in fact, there were privileges granted across state lines, which is important in the state of Maryland because we are close to many other states, Delaware, Virginia, DC, Pennsylvania, and so forth. So during the COVID period, there were complimentary like licensure for that period of time, because physicians are licensed by their state, and so and Medicare and other insurers were paying for telehealth during that period. Well, of course, now the COVID emergency hopefully is gone and stays gone. And so then there was a period of time where we were told that it wasn't going to be covered anymore. Particularly, and that was different for different specialties. But in the specialty of neurology, For a while, we were told it wasn't going to be covered. And we were making plans and we were told to stop accepting or making telehealth appointments. Now, the reimbursement for telehealth was extended again. And I think maybe for another year or so, maybe a year and a half. We don't know what's going to happen further beyond that, but it appears that the window of opportunity is open again for that. But in most cases, the reimbursement is not at the level of an in-person appointment. So that, is an issue. In the field of movement disorders, in Parkinson's care, telehealth has its place, but it is not a replacement for an in-person visit, because we really need to be able to see people move, the way their whole body moves, the way they walk down a hallway. We need to look at their balance by seeing their entire body as they're moving and turning, for example. And we need to actually put our hands on their body and see how rigid or increased in tone or stiff their body parts are, for example. There are lots of parts of the exam that cannot be done on telehealth. So I think that, there are people who live far away, who are more disabled. They have very good reason for not wanting to come into the office, but there'll never be a time where the quality of care is adequate to only rely on telehealth.
Are there any supplements that you would recommend to help with Parkinson's?
During the course of the 30 years I've been doing this, I've participated in a lot of clinical trials, and there were a number of clinical trials looking at supplements. There were studies looking at vitamin E, there were studies looking at coenzyme Q, and others. And none of those studies ever demonstrated a benefit. So we don't have any data to support the use of supplements. Now, we also don't have data to show that it's detrimental, but we haven't been able to show that it improves the symptoms of Parkinson's disease.
Would caffeine be good for a Parkinson's patient? Maybe give a jolt or a lift?
Well, caffeine, one of the funny jokes about Parkinson's disease studies has been that some things that we don't want to even much talk about have been shown to be helpful. And what I mean by that is that smoking has clearly been shown time and time again to reduce the risk of Parkinson's disease.
Really?
We don't talk about it because who wants to say that? But the truth is that you can find that in many studies. It reduces the risk. And, nicotine derivatives have been looked at for treatment. There have been studies of nicotine derivatives. And coffee also, to some extent, was shown to have some potential benefit. Having said that, if you have a tremor, you might just imagine, as you'd imagine, a strong cup of coffee is going to increase your tremor, just like it would cause a tremor in any of us. So it would be a double-edged sword.
Okay. I have been appalled at the continued disparities between health outcomes for African Americans and white Americans. What is Maryland doing to address this?
Well, I guess I should really start by saying that I'm currently principal investigator in a nationwide study to study racial disparities in Parkinson's disease. And, at long last, the National Institute of Health made a priority to study health disparities in recent years. Prior to that, it was not, you couldn't get funded to study that kind of thing. Another incredible fact is that at not only our Parkinson's Center in Baltimore, downtown Baltimore, but also in other cities in the US that are majority African American populations. The Black population who goes to these Parkinson's disease centers is way lower than the white population. And so a looming question is if that is only an access to care issue, an issue of maybe a bias for referral, or financial, issue, or are there biological differences between Parkinson's disease in Blacks versus whites, for example. So that is what we're studying in our study right now, and we are recruiting as many African American Parkinson's populations as we can find. So as far as what can be done, I think part of it is, as we're trying to do, is to understand the mechanism for the problem, to rectify it. I would ask you, in your organization, do you have the diversity that you would anticipate?
No.
Right.
Mm.
It's unexplained.
Hmm?
It's unexplained.
Mm-hmm.
And, I think it's not an easy question to answer, actually. It would be very difficult because to really try to answer the question, you would need to do a community-based study, which are very, very difficult to do and very costly to do.
I've thought about it a lot, but I haven't come up with anything really. What I think is going to be the last question. I'm wondering if you think the trend of medical systems being owned by private equity firms is helpful or hurting the providers themselves. Are there financial incentives for doctors to join such corporations? And are the patient loads more manageable?
Well, I mean, I think that the corporatization of healthcare has in general not been good for medical care, for quality medical care, because it tends to emphasize more and more of the profit margin, especially if it's a very, very large company. I mean, they're just so far away from the actual doctor-patient relationship that just isn't something that's very much on their mind. I mean, we really struggle to get our patients to have the medications and testing that they need all the time. And sometimes it just comes down to, I have one-to-one conversations called peer-to-peer discussions with people who are, but they're not peers. That's very often the case. That oftentimes I'm speaking to, it could be a nurse, and not to say that there's anything wrong with a nurse, except that it's not somebody who knows anything much about Parkinson's disease. So instead, it's like a matter of trying to explain why we really need this medicine or this test, and it kind of doesn't go anywhere. I think it's the more you have these very large organizations who are managing healthcare, the harder it is to plead the case of an individual patient. It's just it doesn't have that private, personal kind of, that isn't one of their goals, really. So I think it has not been good for medical care in general.
Okay, no more questions. I want to thank everybody for your questions. I think they were terrific questions, and thank you for participating this evening. Dr. Schulman, thank you for participating this evening. Very, very interesting, informative session here. Lots of food for thought, I think. Don't forget, everybody, when you get your evaluations, to please fill it out and send them in. It's very important for us. And thank you again, and have a good evening, everybody.
Thank you.